Good afternoon. I'm Christine Dodd, Executive Director of Member Services at the Center for Health Affairs here in Cleveland. I'm delighted to be here with you this afternoon to discuss emerging trends in the federal funding landscape with our grant writing partner and consultant, Innovative Funding Partners. They have over a decade of experience with 20 seasoned writers virtually across the country and have helped us a lot in outlining some of our grant priorities. And they have an 80% track record, which is very impressive in securing federal grants, and have worked across the landscape in healthcare, human services, technology, but have a real specialty in healthcare. And we're delighted to have you with us today. And Louise, I will turn it over to you if you want to start the presentation.
Great. Thank you so much, Christine. So I'm Louise Mathias. I'm one of the two senior partners at IFP. And as Christine mentioned, we're going to be talking about emerging trends in federal healthcare funding today. And I'm joined by my two colleagues, Carrie Davis and Brian Kelley. So as Christine mentioned, we are a grant writing consulting firm, and we have a large team and an 80% success rate. And we do work in a diverse number of sectors. Healthcare is really our specialty, but we work in a lot of the social determinants of health areas and other community development areas as well. And a little bit about me, I've been doing this for about 20 years now, really specializing in healthcare, but spanning multiple sectors, including behavioral and mental health, community development, workforce development, higher education, affordable housing, and some other sectors too. I do have extensive experience with large-scale healthcare system transformation projects, including a lot of the CMS and CMMI demos and pilots. And I'm particularly passionate about projects that seek to reduce disparities and promote health equity. Brian, did you want to introduce yourself?
Yes, thank you, Louise. My name is Brian Kelley, and I'm also one of the senior partners and owners. And my background is in psychology, neuroscience, pharmacology, and toxicology, having done a fellowship in psychiatry and neurology in a hospital setting. So I've done research extensively from bench to bedside to community, including writing a lot of grants to fund my own research, as well as being a grant writer to support larger projects across the healthcare system at the time. And then I moved into doing consulting work, and in that space have written grants across every major federal agency across most topics in healthcare, behavioral health, and community service organizations. Carrie?
Thanks, Brian. Yes, my name is Carrie Davis, and I'm a senior grants consultant with IFP. I've been a grant writer for about 17 years, really working in a variety of sectors as well, but I would say specializing in healthcare, and the majority of my experience has been within the healthcare realm, working with both foundation and federal grant applications. So I'm really looking forward to this presentation today.
Okay, Carrie, I think you're going to kick us off.
All right, so our agenda today is really focusing on two things, the current federal funding landscape, and then also talking about some of the priorities that we're seeing within federal funding, and then also how we can develop a competitive application. So we thought it might be helpful just initially to give some context around what we're seeing as the current federal funding landscape. So some information here to share. It's a lot of data, but I'm just going to touch on a few of the key points for you all today. So $2.2 trillion has been obligated this year for spending by the federal government. 26.6% of that has been designated to the Department of Health and Human Services, which is really a variety of agencies like HRSA, NIH, SAMHSA, and others listed here, and others that aren't listed here. A lot of this is tied to the COVID spending, which obviously you're probably all very aware has sort of been the core of a lot of the healthcare funding we've been seeing over the last couple of years, primarily through the CARES Act and the American Rescue Plan Act. And so just a few points we wanted to make today, that there has been $4.1 trillion already obligated out of $4.6 trillion within these two acts. This includes things like grants, contracts, loans, and even direct assistance to individuals. 21.7 million awards have been made. This is across all agencies, not just Department of Health. And then when we look at Department of Health specifically, $487 billion of that has been allocated already. DHHS, so the Department of Health and Human Services, has made almost 32,500 awards, totaling almost $326 billion thus far. So some of this money obviously has already been spent and awarded out through grants and contracts and things like that. But then there's obviously still quite a bit left that we expect we will be seeing here over the next year. To talk just briefly, more specifically about the American Rescue Act that was passed last March, so a year ago. That was a $1.9 trillion package, and it really focused on a variety of things tied to COVID, vaccinations, keeping schools open, testing and masking, and then also some around economic recovery. I'm not going to go into a lot of detail on these next few slides, but I wanted to make sure everyone was aware that within all of this funding that we're talking about that DHHS has been allocated, there's some very specific categories in which we're seeing grants and contracts and things, falling into. So things like testing and vaccinations, the vaccine confidence education program. So a lot of this funding has actually already been allocated. So if you've probably seen grants coming out over the last couple of years. So some of this has already been spent, but this is sort of kind of an overview of the key program areas that they've been focusing on. So obviously behavioral health. So some of that is tied to workforce education and training. Some of that is maybe specific to pediatric mental health care. Substance use disorder services, enhancing and expanding public health workforces across the country, and then other sort of professional education and training. So things like graduate medical education, as well as behavioral health training for healthcare professionals. Obviously, as we see, the COVID pandemic's impact on our healthcare professionals, just being able to provide support and services to them as well. We are also seeing more and more tied to other areas of mental and behavioral health, including direct services. So we wanted to bring to your attention a few upcoming grants that we are aware of that will be coming out here in the next few weeks that may be of interest to you. And this is just a very small subset of opportunities. So this first one here is the HRSA Community Health Worker and Paraprofessional Training Program. So this one was actually scheduled to be released back in February. It has not yet been released, but it is still forecasted. So we are still anticipating that this grant will be coming out soon. There's approximately $3 million available for grantees. If you look at sort of the total award amount and then the number of awards they anticipate making. So this program really is focused on expanding the public health workforce, like I mentioned earlier, focused on training new community health workers, as well as expanding the skills and knowledge of current community health workers. So that's really the focus of this opportunity. And we are keeping our eyes open and expecting that this one will be released very soon. The next grant we wanted to touch on is the pilot projects to address factors contributing to structural racism in public health. So this one we anticipate being posted this week, according to grants.gov, with a deadline of June 1st. And these grants are between $400,000 and $500,000 and are really focused on policies that will address and mitigate health disparities and structural racism within the healthcare setting. And then finally, the last grant we wanted to mention is the CDC Closing the Gap with Social Determinants of Health. As Brian and Louise will talk about shortly, pretty much every grant we're seeing within healthcare is really focusing on ensuring that it's part of your project is focusing on social determinants of health and how are we as a larger community working together to address those social determinants of health. And so here's one grant opportunity that is obviously very specific to that. It's not a huge dollar amount, $145,000, but the purpose of this really is to develop action plans within communities or states in order to address the social determinants of health issues, chronic health conditions, and really better serving those people experiencing health disparities and inequality. So with that, I'm going to turn it over to Louise.
Thanks, Carrie. So I thought it would be helpful for us to kind of highlight some of those key areas of interest that the federal government has right now in terms of grant opportunities, and then talk a little bit about the key agencies within the federal government that support these areas of interest. So health equity and racial equity has been a huge priority for the federal government in the last couple of years. And you can see opportunities around this from HRSA, CDC, OMH, and NIH. But having said that, what we're seeing is that almost all federal grants now really do require some strategies to address racial equity within the proposal itself. So even if the opportunity is for something that doesn't seem specific to health equity or racial equity, you're still required to discuss how you will address this issue. Mental behavioral health has been a big push too. Obviously, there's just a lot more conversation around mental and behavioral health. It was already, of course, a challenge in most communities pre-COVID and has become a bigger challenge during the pandemic and sort of post-pandemic. So we're seeing many opportunities from SAMHSA, HRSA, NIMH, and DOJ, for example, but not necessarily limited to those. And again, even if it's a grant that is outside of the sort of general parameters of mental and behavioral health, you're often asked to talk about how you'll address that, since that would be considered a social determinant of health. And specific to social determinants of health, CDC, HRSA, CMMI, HUD, ACF, DOJ, USDA. USDA is primarily focused on rural communities. I always like to throw out that disclaimer. But again, you'll see some grants that are very specific to addressing social determinants of health, like the one that Carrie just mentioned. But all grant opportunities will ask you to provide some discussion around how you're going to address those in your application. Community coalitions, we've seen this really started, I'd say, about 5 years ago, this emphasis on community coalitions within federal grants. More and more what we're seeing is that the federal government wants to see that you're collaborating with other organizations in the community to solve problems. And so we're going to talk about this in considerable depth. This really is around leveraging resources and avoiding duplication of effort. So, by working with other organizations, you can, make those federal dollars go further, have more of an impact, et cetera. So some of the agencies that are particularly interested in community coalitions are HRSA, SAMHSA, and the CDC. And then workforce and economic development has been the big push. As Carrie mentioned, there was a lot of funding in the ARPA Act, around this. And so these opportunities are coming out through agencies like DOL, ETA, and the USDA. Again, USDA more specific to rural communities. And again, regardless of the focus area, almost all federal grants now require strategies to address racial equity and address social determinants of health. So I'm sure this is something you're already thinking about and is a priority within your organization, and you'll have the opportunity to discuss that in pretty much any federal application you work on. So as I mentioned, we're going to talk quite a lot about effective collaboration and what that really means, since that is something that is an increasing priority with federal grants. So we always like to say that you want to make progress with your community and not to your community. So this is where working with a coalition of community partners can be really helpful to make sure that really the project is designed in such a way that the community itself, has input. So that might be things like, conducting focus groups and, really listening to the folks that your project is hopefully going to impact and helping them or bringing them in to helping design the program itself. And why are community collaborations and coalitions so important? Well, as I mentioned before, the federal grant, opportunities are now sort of requiring this collaborative approach to addressing community issues. But beyond that, it's really a great way to sort of formalize existing more informal partnerships you already have in place. So when you decide to pursue a federal grant, and it is one that requires community collaboration, it allows you then to reach out to all those organizations that you have, perhaps somewhat informal partnerships. Perhaps you're referring patients there, you have, you serve on some other coalition, you see them at board meetings or whatever it is, and then allows you to put more structure around what you're already doing, which can be really wonderful for the community and really result in, a higher impact project. This does require as much upfront planning as possible. However, when you have a lot of cooks in the kitchen, and everybody's got their own ideas about what a project should look like, you really want to get started as early as possible. So we're going to talk a little bit about how you can do that. But as much upfront planning as you can, really do is going to be really helpful in terms of your project design and having a well-written and competitive application. And I think one of the most important things is really having those clearly defined roles and responsibilities. And federal grants that are focused on community coalitions will usually require you to provide an MOU. But even if they don't, this is a best practice. You really want to understand who's responsible for what and what the various roles are. It's really important to kind of figure out who else in your region may be interested in applying for a grant that might fall into this area. Whenever possible, we always advise collaborating rather than competing, because realistically, the way the federal grant review process works is, they do have a very transparent scoring process. However, they do tend to make final decisions somewhat based on geography. So if it's a federal grant that has, say, 20 awards, the likelihood of them making 2 in the same geographic region is pretty small. So unless there are, really compelling reasons not to collaborate, yes, I think you want to err on the side of, joining forces on a collaborative application rather than competing with other organizations within your same community. So really, what does community engagement look like? It needs to come from the pressing issues that are noted in the local data. So when you're working on a grant application, of course, you have to provide that local data that supports what your approach is. So really looking at community health needs assessments and how the data might be changing or trending, in the last couple of years, what you see the emerging urgent issues being, some of these will not be necessarily captured in your most recent community needs assessment, because if you're doing it every 3 years, your last one might have been pre-COVID, right? And so, we're also seeing that things like folks, not getting their preventative screenings over the last couple of years, are really going to sort of change what some of the health issues in the next few years are going to be. So you want to keep that in mind. So starting with your community health needs assessment is a good place to begin, but then think about, what's been shifting and changing in the last couple of years that might impact what your next one looks like. Thinking about what groups and individuals might have been missed in the community health needs assessment. So there might be shifting demographics in your community, which, might not have been captured in that most recent community health needs assessment. And then really where you have the expertise and the capacity to make, a profound impact. So there are many reasons to start or expand a community effort. Again, if there's an urgent situation that is very specific to your community, it might be, that your community has a high rate of opioid overdose or a low rate of health literacy, et cetera. It also really supports the future health of the community. So by working together, you can have a long-term impact. Obtaining, providing, or improving services, of course. effective and efficient delivery of programs. So again, you know, avoiding that kind of duplication of effort by leveraging resources. To increase communication amongst groups and help reduce barriers. There's nothing like working on a federal grant together to get to know each other and to understand, you know, what each other's sort of concerns are. It really allows you to kind of, like I said, formalize an informal relationship and really understand what other organizations in your community are doing and how you might work together more effectively. Of course, to plan and launch community-wide initiatives, develop and use political clout, and most importantly, to create that kind of long-term, you know, social change. And also to reduce costs. So by, you know, leveraging resources and really addressing those social determinants of health, you know, you can really have an impact on some of those things like hospital, you know, readmissions, emergency room utilization, et cetera, which can be very costly for the hospital and the consumer. So in looking at what might be part of your coalition, you know, of course, it depends on the project itself, but some of the different sectors you'll want to consider would be making sure that you're reaching specific demographic groups, parents, caregivers, patients, et cetera, local businesses, media, school, youth or elderly or other age-specific serving organizations, law enforcement or the courts. Certainly this is, you know, absolutely critical with most, you know, OUD or SUD type of grants. Religious or fraternal organizations, you know, really working with faith-based organizations in the community can help you reach folks who might be, you know, a little bit reluctant to talk to a healthcare provider, perhaps about some of the struggles that they're experiencing. They might be more comfortable speaking about that within the church that they go to or whatever it is. Civic and volunteer groups, healthcare, of course, transportation departments, state, local, or tribal governmental agencies, recreation departments or athletic groups, and any other organization you can think of that is involved in community health. Now, not every grant is going to have all of these sectors represented, but this is just a list for you to sort of think about as you're considering who you might like to partner with. So really, I know I'm preaching to the choir when I speak about social determinants of health, but we know that there are so many factors that influence somebody's healthcare, right? And so, you know, if you imagine an acutely sick patient going to pick up their prescription from the hospital pharmacy, and then, you know, they're told to go home and rest. But rest is not a priority in their life because there's other pressing issues. You know, they have to go to work so they can provide for their family or pay their rent. They don't have a means of transportation. They may not even have a home to recover in. They may not have healthy food to eat. They're going to have a more compromised recovery than somebody that has those kind of assets and comforts in their life. So, you know, really thinking through how do we support this individual in making sure that they have, you know, all of these necessary factors to be able to prioritize their health or their mental health. And so, you know, thinking through what factors would influence the intensity of their condition, their diagnosis, and their recovery trajectory is very important. So now we're going to talk about how you can make sure that your project is really aligned with the NOFO, the Notice of Funding Opportunity, and how you can understand the grant requirements and make sure that basically that your application is a good fit for the grant that you're pursuing. This is something that we spend a lot of time with our clients on because we really want to make sure that our clients are pursuing a grant where they have a decent shot at getting it. It's a huge time investment. It's a financial investment to pursue a federal grant. And so, and then of course, if you get the grant, you have to actually, you know, implement the project. So you really want to think about, you know, is this a good fit for us? And ensure that you're not just sort of chasing dollars, that it really does make sense for your organization to be pursuing this. So first and foremost, you really want to look at the eligibility. This might be around, what kind of organization the lead applicant can be. Can it be a hospital, or does it have to be the local health department, for example? Looking at that funding amount and that budget and really thinking through, is this enough funding to frankly be worth pursuing? Is it going to get you where you want to be in terms of project implementation, staffing, any equipment that you might need, and so forth? What the priorities are and what the required outcome measures are. And then this is one that I think is really critical that folks might not necessarily have at the forefront of their mind. And that is, what are the goals of the grant and the funding agency? So a lot of times when we're looking at grants, we're thinking about, what can this grant do for our organization or for our community? And of course, those are critical things to consider. But it's important to remember that agencies are looking for and required to fund projects that fulfill their mission and the authority of the law, the legislative purpose, et cetera. So when the federal government appropriates funds for a specific grant opportunity, it's because they want to see certain outcomes. So if your project, even if it's really innovative and it's going to change lives, if it doesn't help the agency achieve those goals, it will not be funded. So we always tell clients and review with clients, looking at that purpose of the funding paragraph that is in most RFPs or NOFOs, where it really outlines, what the federal agency wants to see happen as a result of the project and what the eligible use of funding is.
Thank you, Louise. Our next section is going to be on data outcomes and evaluation. And oftentimes in the community, that's really discussed as creating impact or making a difference in people's lives. And I think more so than probably any other section of a federal grant, the sections around the methodology and approach and evaluation is really dramatically increased in rigor. For example, just 10, 15 years ago, a HRSA grant, there'd be very limited data collection and evaluation. And more recently, I've seen some HRSA grants that required, control groups being compared to intervention groups, which really is increasing the complexity of those types of those grants, especially the design of it. So there's been a big shift in and now looking at really tangible, concrete outcomes that are showing a positive impact of that effort on measures that are important to people in the community as well as the federal government. Like truly changing lives is what they're looking to do, especially in healthcare. Ultimately healthier people, right, at a reduced cost, the quadruple aim. So it is not surprising to find out that most grants, specifically coming out of like HRSA and SAMHSA and CDC, as a prerequisite for their approach section, you have to describe how your project is going to be smart. And I always say, don't make it smart, make it smarter. So these grants now require to be very, very specific. Target a specific area for improvement. Or target certain efforts for change, like diabetes, like depression episodes in the emergency room, opioid overdose in the community. So they want to know that you have a very, very specific, concrete, well-defined area for improvement that you're looking at. Next to that, it has to be measurable. They want you to quantify or at least suggest a indicator of progress. And this is pretty straightforward, really. If you say that your project is working, is really producing impressive outcomes, the first question would be, what outcomes are changing? So you really need to think early on about what you have access to, like what can you actually measure? And of all those things that you can measure, which ones are the best indicators of the progress or success of your project? The next part of the smarter model is assignable, right? You have to be able to assign tasks to specific people across a timeline. So if someone isn't doing it, it's not likely to get done, right? So if you don't have, people within your organization whose names that who you can talk to, face-to-face or via email, and get their assurance that they do have the time that they can dedicate to this task. And you fill up your grant with a bunch of to be hired. One, it's not likely to be reviewed very well, but even if you get the grant, it's going to be really hard to pull off if you can't quickly, talk to people about those specific tasks and their ability to get them done and get them done on the time requirements of the grant. Now, this next one is being realistic. That's one that I always struggle with. I mean, I always have really exciting grand visions for the projects that I want to work on, as I think we all should. But those goals that I have to be realistic. So they're oftentimes tempered by things like budget and the amount of time given for the project. So, I mean, a 2-year grant with several $100,000 can only accomplish so much. It might be more of a proof of concept or pilot type of project, right? But if you have a 5-year grant that, that has many millions of dollars, obviously you want to equilibrate the time and money to the goals that you have. And I think, the federal government especially wants to see that you're doing the most that you can with the money and resources provided. But at the same time, you don't want to put yourself in a situation, as Louise noted previously, where you put together a project which can be done only under the guides of the grant and becomes unsustainable once it's finished because of resources. So you want it to be realistic and you want it to be, achievable. The next one has to be time related, which sort of goes to the realistic part. When can you honestly expect to begin to see positive outcomes? If you're trying to achieve, let's say, reduced A1C levels in a high-risk population, and in the grant, you're expecting to see that happen in the first 3 weeks of the grant, I think people are going to obviously see that it's not being very, very realistic. Is 6 months realistic for the first time point where you're expecting to see a drop in some of these metrics, or 9 months, or a year? So it's really critical to kind of be realistic about the time factors about when you can get stuff done. The next part is the ER that I add to the SMART model, the SMART-ER model. You should always be evaluating your metrics. That is, evaluating your data. And I don't say not necessarily real time, but I think as the project starts, as real time as possible, make sure that you are actually being able to accomplish what you're saying you are going to accomplish. If you can't accomplish it the first quarter, it's going to be hard to continue to build success when you're not having success early on, because things might not be going right. So that early evaluation of data can really help make an informed decision about if you have the right staff, if you're actually collecting the right metrics, if you're reaching out to the appropriate patient population. And then after that evaluation phase, which probably is more intense, more rigorous early on, you can begin to reevaluate it maybe every quarter, every 6 months, every 9 months, or every year, and just make sure that you have a model for using that data to continue to make informed decisions about that particular project. This is called the closing the loop system that a lot of federal grants are expecting, and that is, how are you using data across your project to inform your leaders so they can improve the project, during the time parameters of the project. So what you start with your project is not necessarily what you're going to end with, because you should be across every data evaluation cycle having more information and be able to make better decisions about your intervention or your program or your outreach effort. So this gets down to even things that are more specific. What is your research topic? What is your research question? And ultimately, what do you really hope to achieve? And you need to be able to tie data points and the term improvement to those data points across time and potentially space. Grants get funded because of good ideas. They get funded again because of good data. So that's something really, really important to keep in mind. So when it comes to data, we don't have an infinite array of options. We really only have 4 ways in which we can measure things. And that is, knowledge, skills, attitudes, and behavior. So a lot of times in our more formal education, we tend to be assessed on knowledge, maybe at some respects in clinical practice, skills, and maybe attitude for being able to overcome challenges. But in reality, all of those, even combined, pale in comparison to the importance of behavior as an outcome measure, as an indicator. And as a quick example, I've done a lot of work in smoking cessation and substance abuse. And what you find out if you do a person on the street interview, that non-smokers surprisingly don't have a lot of knowledge about, smoking risk and adverse effects of it. You'd probably find out that daily smokers know a lot more about the adverse consequences of smoking than non-smokers. So even if you improve a smoker's knowledge and you help improve their skills and really enhance their attitude about quitting, if they don't actually reduce the smoking behavior, none of that's going to matter very much. That's why I think it's really, really important for these federal grants to make sure that part of your indicators, part of your measures are really focused on behaviors. Like, is the patient/client actually reducing their cigarette use? Is the diabetic actually showing a drop in A1C levels, right? Is a person with knee replacement going to physical therapy and showing an increase in mobility and strength related to that joint, and so on and so on. Those outcomes tend to be way more influential. Even one or two behavioral change metrics tends to be a lot more powerful than a whole bunch of metrics around knowledge, skills, and attitude. So then the question is, well, if you can't pick behaviors as a metric, then you really should pick all three of the other ones, right? But beyond that, when you're asked to even consider what should you include as a metric, I mean, what behaviors, what measures of knowledge, what changes in skills, what changes in attitudes and perceptions, I would suggest that you pick those that first and foremost are important to the organization or federal agency providing funding. They oftentimes lay out in their, RFP, that is their grant announcement, what they're hoping to see in terms of outcomes. Maybe it's not super precise, but if they're talking about, diabetes, and you're going to see things like blood sugar, A1C levels, reduced ER utilization, stuff like that. Those are all things that are related to behavior. So doing a training, a workshop on better eating, helping individuals do a better job deciding what to eat, and helping build their attitudes around positive change, none of those are going to matter very much if you don't see, reduction in A1C levels, reduction in emergency room utilization, and a spread out of those, visits to the healthcare system because the person's getting healthier. So target the outcome measures based on what are priorities for the funding organization. Also, you should focus on outcome measures that are specific to your research or program goals, right? I don't suggest, expanding your data collection efforts too broadly to, as Louise noted, to fit into a grant that maybe doesn't align well with your strategic priorities, because it might seem surprising to some, but collecting data, analyzing it, making sense of it takes a lot of work, especially if you're asking busy clinical staff to add just one more item to, what they're asking of patients. So that's a double burden now of the clinical staff as well as the patient, and then a burden on the grant team to actually analyze and make sense of that. Also, make sure you're picking data points that are important to your organization. So Louise talked about social determinants of health, talked about, equity, equality, racial justice issues. So make sure that if those are important to your organization, those things materialize in your project. And I would say, to the first point of this presentation, pick measures that are important to your stakeholders. Make sure you're doing things with people and not to people. And part of that is making sure that you're collecting data that they're comfortable providing that's also impactful. Also, make sure that you're collecting data, and this is a priority for the federal government, that can generalize to and be disseminated to a larger audience. The federal government provides funds to do projects in Cleveland, in part to hopefully improve the lives of people living in Cleveland, but they also want to take that knowledge gain and be able to take it to Pittsburgh or St. Louis or another city or another maybe demographic group or something like that. So they're not providing these funds just to be kind, or providing these funds to test various models in different locations and find those models that work best, and then provide additional funds to generalize and disseminate those best practices to a broader audience. So luckily, many organizations already have expertise collecting data. I mean, the emergency room collects a lot of data. Healthcare organizations in general collect a lot of data. So I suggest, following the, when I say the 90-10 rule, for every project that you do and every iteration of it, I wouldn't add probably more than 10% new data to that project. If you add too much data, it might be hard to collect. You might have a hard time interpreting it. You might have a lot of gaps in that data collection because it is new. It require a lot of additional training. So I'd say try to keep it simple and keep the additional layer of data, for each project to a minimum, while also at the same time, achieving the goals of the project and still, being rigorous in terms of design. So when it comes to collecting data, I try to simplify things. So I call it this, Kelley's 4 Ds of the dependent measure. That is your outcome measure. That is your metric. So if you're looking at depression, for example, first and foremost, you have to define what it is. And some of that might be from organizations, societies like the APA or something like that. But you should have a relatively consensus-driven definition of what that is. Then you should be able to describe it in the context of your project. And part of that measurement is going to be an expansion of that definition into an instrument, let's say, for depression. It's a subjective state. So oftentimes you have to measure that through an instrument. So while you define it, with the definition, you actually describe it in the context of what instrument are you actually using to measure depression or anxiety or substance abuse severity, or, requirements around social determinants of health need. How are you defining that, describing it? The next one is, funders want to see that you've thought a lot about your data. So you should provide a direction of change. Are you expecting this data increase or decrease? Are you expecting depression to go down? I would sure hope so. Expecting A1C levels to go down, expecting emergency room utilization to go down. And then, as you develop real expertise, you should be able to provide a degree of that change. This goes back to, this being smarter, the realistic part. And if you're saying we're expecting a 50% change in, a 50% drop in emergency room utilization because of this intervention for, diabetics, that's probably just not realistic. The reviewers of that grant are going to note that it's not realistic, pretty quickly, and just not have a lot of enthusiasm for that project. Because if your outcome measure is not realistic, what does that say about the rest of the project? So this takes a little deeper dive into the research literature and your team to ask, what realistically can we do to change this outcome measure? How far can we get A1C levels to drop because of this intervention that we're trying to develop? 1 or 2 points, 3 points, maybe. So again, define your term, your construct, your outcome measure, describe it in the context of your specific study with respect to that specific grant, provide a tentative change in direction and degree. And I think in that way, the reviewers of the grant will really know that you have a lot of expertise around this topic. Another framework considering for evaluation is, I call it the 6 Ps. Right? So you should be considering, how things are changing for the patient, how things are changing for the providers, how things might be changing across different places. If you're providing, care in a clinic versus the emergency room versus a mobile clinic that's going to specific areas of the city, how are those places being impacted? And then above that, what programs are you using in these different places with these different providers to impact patients? And then nowadays, it's hard to not discuss this without discussing payers. Who's paying for this stuff, and are we giving them, enhanced benefits through these interventions? Are we improving care while maintaining cost or even reducing cost? And then I always say we should really be evaluating the intersection of all of these things in terms of the processes. And those processes can be complicated too. Like there might be onboarding processes for some of these efforts, right? So I'd say, look at how patients and providers intersect and evaluate that. Providers and places and programs, programs and payers, patients and payers, and so on. So there's lots of layers here that can provide a framework for evaluation. And of course, the best evaluation is that is suggested and modeled by the funding opportunity. So make sure that you're looking at what they're requesting for evaluation. If I had to guess, it would probably in some way be modeled off this diagram right here. So this is just a good way to conceptualize how to consider the different layers of evaluation that you might have to do. So now we're going to talk about how to take all that information there and embed it into what we hope would be an effective program. So the question is, what is an effective program? Obviously one that changes those metrics in a positive way that's sustainable, and that of course uses evidence-based best practices. So when it comes to making decisions around evidence-based best practices, Most of the time, the grant will provide some guidelines around that. But even if it doesn't, just, some insight from our years and years of doing this, if SAMHSA is providing the grant, I guarantee you SAMHSA has a lot of content in that space around that topic. Probably wise to reference SAMHSA-based materials in a SAMHSA grant. The same way it'd be wise to reference CDC materials in a CDC grant. SAMHSA and CDC didn't spend many, many decades funding projects to create best practices and toolkits and training guides for those to be ignored and for someone to basically create their own model that's not evidence-based, that's not part of the literature. So I always say start with the recommendations from the funding organization. And if there's more specific recommendations in the grant, then I would certainly start there and maybe add to those, but certainly probably not subtract from them. So when it comes to the definition of evidence-based best practices, you're relying on three intersecting, areas, individual clinical expertise, like what is your staff able to do in terms of delivering these best practices? It might be that if there's 3 or 4 best practices, your staff might be best equipped for 1 or 2, but maybe not all of those, right? What's the best external evidence to support the rationale for those interventions? And that's basically a literature review. And maybe interviews with experts. And the last one, and not the least important one at all, but what are the patient's values and expectations? How are you including the patient in this process? The programs that are going to work best are the ones that are again, done with people, not to people. So if the patients are involved in decision-making around some of these programs and practices and interventions, they'll probably be a lot more successful. Right. And then, of course, the question is, what type of intervention are you proposing across the care continuum, right? From prevention to treatment to recovery. So again, this oftentimes is a pretty laborious process just to figure out, what your organization is capable of doing and what it might be capable of doing or even more with other organizations partnering with you. What does the literature say? And who would be providing that literature? What experts could be weighing in? And then, of course, what does the community say would be most impactful and important to them? So I would look at all 3 of these, areas as you're making decisions about how to develop and implement an intervention program for a grant, because that's what they're going to be looking for in terms of their evaluation of it. Of course, historically, whenever we thought about interventions, it's almost always been treatment focused. That's just the nature of how healthcare has worked historically. And when people present to the emergency room, you really have no choice but to treat them. But really, treatment in that case is very, very expensive and oftentimes not always as effective as other modes of intervention. So now the federal government is really asking what can be done in terms of health promotion with the goal of, reducing treatment through people having better health. So how can we engage in health promotion? And then we have prevention, which I'm not going to cover all of these. You probably have some knowledge of them, but is it universal prevention, selective prevention, or indicated prevention? And then there's different costs and benefits for each one of these. And then, of course, how can we improve treatment, right? And then after that, what can we do in the recovery process? There's been a lot of focus right now on when people leave the healthcare system, why they just keep coming back to, in some cases, the ER within hours or sometimes days. And that gets to those discharge instructions and collaboration with community organizations to address those social determinants that are oftentimes the factors that are moving people back to less health and back to the emergency room as a point of care. So, the federal government wants to see that promotion, prevention, and recovery are being addressed oftentimes by focusing on those social determinants of health that are drivers for those issues. So if you're not talking about the continuum of care in your health-related grant project, you're probably missing a really important part of that grant process. And in order to accomplish all of these, you're probably going to have obviously more organizations involved than just the healthcare system. This might be one of my favorite slides, and it was derived in part from some work done by CADCA. But really, this captures, strategies that are effective at producing, behavioral change, community change, and those that are also hard to achieve. And what we find out is that things that are easy to do oftentimes are the least effective, and things that are hard to do, unsurprisingly, are the most effective. I'm not going to cover all of these, but we've learned through a lot of research that just providing information, again, going back to the smoking cessation example, finding a smoker and giving that smoker a pamphlet on how bad smoking is to their health tends to have very, very little impact on behavioral change. And the behavioral change I'm discussing specifically is that person quitting smoking. Going all the way up to the very, very top, we were changing law and policy to increase the smoking age from 18 to 21, increasing the tax for cigarettes. Factors like that oftentimes have, based on research, predictable outcomes. Simply increasing the cost of cigarettes tends to reduce the number of people under 25 that smoke, because their disposable income oftentimes can't accommodate an increase in the cost of cigarettes. Of course, when it comes to mental health care, having that care in an area of town that's hard to get to, if you're taking a bus, might require 2 or 3 buses, would be very hard for people to get to, especially knowing that mental health issues tend to produce real challenges in motivation to seek treatment, not even including things like stigma. So moving mental health facilities closer to the target audience, providing telehealth are really strong ways to, change that physical space, that physical design, and thereby reduce barriers. So I always tell folks, consider each one of these 7 levels and think, what's the highest level of impact that you can create with this grant or through this program? And it might be there's a couple of them that for the first year, you're enhancing skills. The next year, it's going to be enhancing skills and providing support. And the year after that, it's going to be enhancing access and reducing barriers. So always try to, from a grant perspective, work your way up this pyramid of impact. So at the end of your project, you actually have something that you can say about policy. How can our data, how can our project inform policy changes in our own community, but also how might we disseminate that policy change to other communities? Okay, so, I did go through the 2019 Community Health Needs Assessment for one of your communities, and these are what showed up as the top priorities, right? Eliminating structural racism, enhancing trust and trustworthiness across sectors, people, communities, addressing community conditions such as poverty and its effects, enhancing mental health and reducing substance use, reducing chronic illness and its effects. And I guess my question, these are great goals, laudable goals. How many of these can be done with just one organization? And these are not organization-specific goals. These are really collaborative community goals that are going to require communities working together and really building transformation across organizations to really impact these. So the last part of our presentation is going to be just that. How do we achieve those big goals around cultural competency? So getting to health equity. So the CDC defines equity as when all members of society enjoy fair and just opportunity to be as healthy as possible. So this requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness, lack of access to good jobs, fair pay, quality education, housing, safe environments, and care. And I think, the biggest difference between equality and equity is that equity, equality is we give everybody the same thing, even though not everybody needs the same thing. And equity really means that we're targeting the work that we're doing to what people actually need when they actually need it. And that's much more relational than equality. We actually have to know our community pretty well to be able to provide those targeted resources. And that's where the social determinants of health type of focus comes in. So this came right from the Center for Disease Control about how we can help address cultural competency. This article was produced in 1989, and they developed this really complicated flow chart. And I find this interesting because it wasn't that many slides ago that I talked about this. You can change knowledge, you can change attitude, you can change skills through a variety of training and onboarding around, racial justice, around cultural competency. But if these 3 things do not result in changes in actual behavior, they're not going to produce the kind of outcomes that you want. So we can train people like crazy around cultural competency, but if we don't start to see those people addressing racial issues, economic issues better, more effectively and efficiently, then we only have changes in knowledge, attitudes, and skills. We're not going to see that dynamic needed change within our healthcare system and community by addressing actual changes in behavior and practices. So when we think about, addressing a community's complex needs, this is what kind of Louise was alluding to earlier. It is complicated, and oftentimes it's generational. And it's going to take a coordinated, collaborative community care approach to address these. And, when we think about housing, how critical that is, economic opportunity, education, and health and wellness. I mean, those are the big things people talk about, but oftentimes we have to look at where these things intersect. I mean, looking at housing, economic opportunity, I mean, those two combined produces stable living. Looking at economic opportunity and education produces equitable finances. Looking at education and health and wellness produces health literacy and a healthy lifestyle. And health and wellness and housing produces a safe, healthy home. So when we think about how are we addressing, really all 8 of these, and how are we building cycles of improvement? And then we have to ask the bigger question, are we looking at this at the level of the individual, maybe the family, maybe a neighborhood, maybe a community, or the entire region? Are we trying to do this for all of Cleveland or for a sub-community in Cleveland as a pilot project? I think building structure around what we're trying to accomplish makes it a lot easier to begin to build those outcome measures to make sure that we're actually accomplishing something. And this is a great slide to sort of capture why we should be doing coalition work, why should we be doing collaborative work. I think a lot of organizations say, you know what, if we can grow, we can serve more people. Of course, serving more people doing the same thing that they're doing. Meals on Wheels is a good example where they might say, you know what, we're serving 100 people a month. We'd really like to expand our site so we can serve 200 people a month. I mean, that's great. That's a great goal. There might be another organization that says, you know what, we're serving 50 people a month and we're addressing something like, food insecurity. What we really want to do is take these 50 people and now add housing instability to it, maybe education to it. But really what should be happening across the community is these organizations should be working together to build not just an increase the number of people that are being served, number of sites doing the service, but also simultaneously addressing more and more root causes. You just can't do that by growing one organization in terms of size or one organization in terms of the number of root causes that are addressed. You really have to grow these organizations through a collaborative approach, through a coalition model, which is what the federal government is trying to support through their grant. So by bringing more organizations together, more people can be served and their impact can be greater in addressing these root causes of problems that are what is oftentimes creating these generational issues. If we want to break generational poverty, if we want to address racial injustice and other issues, we're going to have to do it through a collaborative, transformative approach that is driven by solid data so we can evaluate how we're doing to make sure that we're always doing it better through iterative cycles. And this brings us to opportunities for questions, and hopefully we'll have some answers for those.
Thank you very much, Brian and Innovative Funding Partners, for this excellent presentation. I had a quick question. What is the best way to track these opportunities given the volume of opportunities in today's climate?
Yeah, that's a very, very good question, Christine. I wish there was an easy answer to that. It can be quite time consuming. So, grants.gov is the portal where all of these grant opportunities are published, and they usually publish a forecasting notice. So if you stay on top of grants.gov, you can sign up to get daily emails from them that list all of the grants that have been published that day, including the forecasted opportunities. And if you see something that's forecasted, then you want to keep it on your radar so that you know right away when the NOFO is going to be released. But it's usually best if you have one person within the organization that's sort of charged with staying on top of this, because otherwise what we're finding is that folks tend to miss things. Maybe you're on a listserv and you get an opportunity here or there, but then by the time you find out a grant is out, it's like due in 10 days. It's too late. Yeah.
With the changing census in Cleveland and the changing environment, is there anything here we should do to look at our policies and procedures and practices?
Yeah, one thing that's a priority for the federal government is making sure that every member of the community, is addressed in that grant. And sometimes it's hard to know who's in our community. So oftentimes with changing demographics, we're going to be sure that there's not a growing or shrinking population that we are unaware of, particularly with just the mobility of people across our nation and from even other countries. We want to make sure that if we see an increase in a population that speaks a different language that's typically presented in the healthcare system, that we're able to be ahead of that and not behind it. So that's one of the benefits of just sort of being on the lookout for changing in, you know, census demographic related variables while we're providing, you know, care for folks.
Thank you. And how long does the program design while we're waiting for the NOFO to come out? Is that something we should be doing well in advance, talking to our community partners?
Yeah, I think if you wait till the grant's announced to begin working on it, you're not going to get it done in time, especially so given that so many grants now require those more complex collaborations. So I think it would be important to you know, build on those coalition types of models, get those moving, begin to talk about, you know, metrics, like who's collecting what data, what are people's expertise and capacity? And then when grants come out, you should be able to align that grant with things that are already in process, as opposed to realigning priorities based on a grant here, a grant there. I think there'll be enough grants to match interests and activities of different groups. So I always say, as Louise noted, better to wait for a good fit than to try to reorganize your efforts around a grant and then miss the deadline and just keep repeating that process.
And just to add on to that, if this has been a recurring grant opportunity, like it's an annual opportunity that comes out every 2 or 3 years, if you look for the NOFO from the last funding round, that'll give you a lot of insight. Now, inevitably, they always make some tweaks or changes, but you can at least see, okay, last funding round, they were requiring, you know, this kind of thing, and start kind of getting your ducks lined up based on that. If it's a brand new opportunity, you know, there's usually not a lot of info to go on, unfortunately. So like Brian says, just having those kinds of conversations with your potential partners and, you know, getting to know what everybody's needs are, what everybody's goals are, just kind of makes it a little bit easier once you get off and running.
Great. Well, I have nothing further. And I just want to say thank you so much for joining us today. And we hope that everyone on the viewing audience enjoyed this and learned something. Thank you.
Thank you.
Thank you.
Glad to be here.